Thank you, Maria, for that introduction. Our objective today is to educate healthcare professionals, caregivers, and community members about hospice, the basics, the benefits, and what it means to be a member of the hospice interdisciplinary team.
The Institute of Medicine conducted a survey, and in the survey they asked people who were diagnosed with a terminal illness and given a life expectancy of 6 months or less to live, where it is that they would want to receive medical care. And 9 out of 10 of those respondents said they wanted to be at home with their loved ones. So what care is available to people at home? Today you're going to hear Inomi and I use the word palliative care and hospice care interchangeably.
What is palliative care? You're going to hear that term throughout the presentation. It's the study and management of patients with active, progressive, and far advanced disease where the prognosis is limited and the focus of care is the quality of life.
As Inomi said, it's not on the quantity of life, but it's on the quality of life. So what does that mean? What does that look like? Well, palliative care, what that does is it affirms life. It gives the control back to the patients. It allows them to determine what kind of care it is that they want at the end of their life. Palliative care regards dying as a normal part of the process. It doesn't hasten or it doesn't postpone death, but it allows that natural death to occur. It focuses on the relief of pain and other symptoms. It integrates not only the physical but the psychological and spiritual aspects of care. It's a holistic approach. And most importantly, it looks at the patient and the family as a unit of care.
Now let's take a look at curative versus palliative. When you think curative, think of healing. For example, if you have a bladder infection, you're going to take an antibiotic. With palliative care, we want you to focus on the comfort and quality of care. Curative is disease-driven. The doctor is in charge. The disease process is primary, and there are few choices. However, with palliative care, it is symptom-driven. The patient and the family members are in charge. The disease process is secondary to the person, and there are many, many choices. So again, when you think palliative care, think comfort and the quality of life. With curative, healing.
Mm-hmm. An example would be, for instance, what we might hear in hospice care is a patient say to us, "I'm tired. I'm tired of the hospitals. I don't want to be in that environment. I want to go home. I want to be with my family. Maybe put my bed out on that sun porch so I can watch the birds and listen to the music. I'm tired of taking all these pills. Is there any way you can talk to the doctor about getting rid of some of them? I want to eat what I want to eat. I know I'm diabetic. I know I should be on a special diet, but I don't like that food, and I want to eat what I want." So these are some of the things that patients will say to us on a day-to-day basis. There are many myths and misconceptions about hospice. First of all, hospice is not a place. Hospice is a delivery of care. It's called palliative care. The focus is on the patient, not the disease. Hospice does not mean giving up or losing hope or just talking about dying. It honors the patient, and it allows us to focus on living until that death occurs. We help to redefine hope. An example would be, maybe it's their hope just to get out of bed and get dressed for the day, or maybe to attend a special event that the family has coming up. Some people would think hospice is not much more than hand-holding. However, hospice is a team of professionals that have special training in end-of-life care. Hospice does not mean doing nothing or stopping all treatments. Again, it's giving choices to the patient and the family and allowing them to make the best decisions for themselves. Hospice care is not expensive. What people don't know is that under the Medicare benefit, there are many things covered at 100%, such as medications and over-the-counter drugs that are related to the terminal diagnosis. It covers some of the medical equipment like your oxygen concentrators or your nebulizer treatments. It covers personal protective equipment. It covers personal briefs and things like that that are needed at end-of-life care. So when you take a look at all those things together, it can be quite a savings to families. Hospice is not just for cancer patients. Hospice covers all end-of-life diseases, such as congestive heart failure, or lung disease, or Alzheimer's, maybe AIDS, many, many diseases. And it is not only for the very old. In fact, there's no age limit. And there are hospices out there that specialize in taking care of children. Patients do not have to be a do not resuscitate. That's a big one. I hear that often as a social worker. We take care of people who want everything. Most usually they change their mind, but we are not there to make their decisions for them, but to alleviate any pain and suffering. There is not a limit to how long a patient can receive hospice care. It's an unlimited benefit period, as long as they're still meeting the eligibility or the criteria for their terminal illness. Hospice care continues 13 months after the patient's death. And the one thing that I hear most often is, why is hospice here in this long-term care facility or in any facility? Is it really needed? Being a social worker on a designated hospice team, I can tell you that there are very specific issues that are addressed by the hospice team. In most facilities, they have a generalist training. And what hospice does is it brings, again, the professional team in that has end-of-life training. And so we are able to address some of those needs in patients specifically at the end of their life. So who makes up this hospice interdisciplinary team? If you can visualize a wagon wheel, and in the center of that wheel is the hub, and that hub is your patients and your family. Patients and family are the core of the hospice team. They are the center of all decision making. So around that center, that patient and family that's in the center, is the team of professionals. And it takes all of us. In order for that wheel to roll smoothly, we need to work together to best address all the needs of the patients and families. Probably the key person of that team is the registered nurse. And in a few minutes, I'll let Inomi give you a little bit more information about the role of the hospice nurse, because it's a big one. Next, we have a home health aide who has probably one of the most intimate relationships with our patients. And so I'll let Inomi take a few minutes and tell you a little bit more about the importance of the hospice home health aide.
Our home health aide is one of the core members of the interdisciplinary team. They see the patients based on the patient's needs for activities of daily living. And what does that mean? It means assisting them with bathing, dressing, transferring them to a wheelchair. They can see that patient 2 to 3 times a week or more often, but it's based on the patient's needs. Also, they can provide social visits. If at times the patient doesn't have many family members and they don't have anyone to visit with them, then they can provide social visits. Also, they're the eyes and ears of that nurse when she's not there. Because they see the patient so many more times a week than we do, then they become experts in delivering that care to the patient. They become experts because the nurses have taught them, given them observation skills to look for changes in that patient. For example, while bathing, they notice that there's a different skin color or there's a break in skin integrity. Then they'll notify the primary care nurse about that, as well as the facility nurse if they're in a facility. And they also will document that as well. The home health aide continues with education, at least one CEU a month. They become companions to our patients. They develop a special relationship. They're always the center and core core members of seeing that patient.
And so important to the families at this time in their life, absolutely. The social worker is another team member of the team, and I will talk a little bit further about that in a few minutes. We also have chaplains, and our chaplains are there to provide pastoral care, spiritual support. They work with the clergy of the patient and family's personal clergy if they have clergy available. They address some of the spiritual symptoms at the end of life, and I'll talk more in depth about that in just a few minutes. Oftentimes, the chaplain and the social worker combined are the psychosocial team, and they work very closely. The next IDT member, or interdisciplinary team member, I'd like to let Inomi expand on a little bit, is the volunteer.
Our volunteers are amazing. They are trained by our volunteer manager. They provide many, many services, such as we have volunteers in the community that provide prayer blankets. We have volunteers in the community that provide Afghans. They make booties, and we distribute it to our patients. They also provide assistance in administrative in our offices. We have a special program at VITAS called the Memory Bears. And what this program is about is the patient may have had a particular article of clothing that they've had, and they give it to our volunteers to make memory bears. For example, I had a patient that was a cook, and the family members took that apron, and we gave it to our volunteers, and they made 3 memory bears out of it, out of the apron. And because this patient was so meticulous in her dress, they added earrings to it as well. And they delivered them to the granddaughters. And that has become a very, very popular part of our volunteers. Also, they provide pet therapy. Wherever the patient may be, they can go in the facilities and visit with them. They can run errands with them. Because we live in a community that has a large veteran population, we try to match the veterans, we try to match our patients with the personalities. For example, since we have so many veterans, a lot of times the veterans will not talk to people other than other veterans about their war experiences. So we match up the personalities, and that has been a great added value for our volunteer services as well as to our patients.
Absolutely, and they love those four-legged pets that come to see them. We also have bereavement specialists, and our bereavement specialists are involved before and after the death. They provide memorial services throughout the year. They provide, of course, the counseling that's needed before and after the death. Sometimes if someone is having a particular hard time in their grief process, they will make connections with the community to get them the help that they need. The next person, or the next 2 people that I'd like to spend some time talking about is the attending physician and the hospice physician. They work very, very closely with the registered nurse on the team. So I'll let Inomi cover all of that.
Thank you, Lucy. Our attending physician is a patient's choice, so keep that in mind. Sometimes the attending physician will turn over that care to the hospice physician because the hospice physicians are experts in that field. The attending physician may or may not follow. That's their decision. Also, our hospice physician is a member of the IDT team. He can make visits to the home if needed. He is involved in the plan of care, and he is a core member of the interdisciplinary team.
And he meets weekly with us.
He meets weekly with the interdisciplinary team as well. Thank you, Lucy.
Mm-hmm.
Now, for the registered nurse, the hospice registered nurse. Oh my, we're hands-on. Just because we're hospice nurses does not mean that we're not hands-on. As soon as we enter that patient's room or their home, we're already observing and assessing. And for you nurses out there, we're still documenting. We're still doing head-to-toe assessments. We're still making sure that the patient's needs are being met. We're managing their physical symptoms, whether it be pain, shortness of breath, anxiety, all those things we're involved with in the management because we've become the expert in that area. We provide education and support. The education could include about weight loss. For example, weight loss is one of the hardest concrete things that patients deal with because the weight loss is gradual. And so we have to teach the caregivers about weight loss and teach them that it's okay not to eat. We're their case managers. We manage their care. We're their communicators. We communicate with the interdisciplinary team. We communicate with the attending physician, with the facility. We become a liaison with the facilities, with the caregivers, again with the interdisciplinary team. And probably most important is communication, to make sure that everybody is on the same page and we know what's happening with that patient. We don't do anything without contacting the family and the doctors that are involved in that patient care. We supervise the home health aide. Each time that we go out to visit our patients, whether they're in their home or in the community, we supervise the home health aide care. Some of the more common end-of-life physical symptoms that you might see is unrelieved pain, respiratory distress, confusion, restlessness. A lot of times that restlessness, we call it terminal restlessness. The patient may become very agitated. They may start picking in the air, or they may see loved ones that have died early on. There's nausea and vomiting. There's a disturbance in their bowel and bladder functions. So those are some of the common end-of-life physical symptoms that we help manage.
And I think what's important to add about that is that all of us as team members are trained to assess for that and to look for that, so that, for instance, if Inomi has been out to see a patient earlier in the week and maybe it's the end of the week, they can change from day to day. And so it's important for us as team members to alert the nurse for any changes that we see. So we're always working together. That's the team approach, and that's why it works. Now I'll take a few minutes and tell you a little bit about the role of a social worker. We wear many, many hats, and I think that what you'll realize is that any one of us on the interdisciplinary team wear many hats, but we also have a great understanding of what our area of expertise is and when to call that person in. As a hospice social worker, my primary goal is to provide emotional support to the patients and their families. I help them to problem solve. I help to connect them with concrete services. Maybe they need home modification repairs. Maybe they need an air conditioning unit. Maybe they need the basic things like food. Maybe I need to contact CPS to let them know they have oxygen in use. If something happens, they need to be alerted. I help with end-of-life planning. Again, it's very important as an interdisciplinary team member to find out what kind of death they want. What are their wishes? What do they want? Do they want to be resuscitated? Do they not want to be resuscitated? If they get to a place where they can't eat anymore, do they want to have artificial nutrition and hydration? These are all difficult issues sometimes to talk about, but very, very necessary. And I think that's one of the things that I've learned from my patients is don't be afraid to have those conversations. Because what I have seen is that if you have the conversations, then when the time comes, the family members don't have to question and feel like the weight of the world is on their shoulders. So helping them with end-of-life planning is very important. One of the roles that I see myself as is an advocate. So I empower patients and families' voices to be heard. I'm a facilitator. I help assess the needs of the patients and families, but I also help refer out into the community when needed, and also facilitate with transfers if they change their level of care, which we'll get to in just a few minutes. I also facilitate in the coordination of care. I'm a communicator, not only with the patients and families, but facility staff. It's crucial. And the hospice interdisciplinary team. I see myself as an educator. As Inomi was saying just a few minutes ago about end-of-life symptoms, Yes. Sometimes, well, what I've learned is that you have to invite people for that information, not assume that they always want it. But oftentimes they do want to know. And by giving them that information, it allows them to know what to expect, and it alleviates some of that anxiety that comes at the end of life and when you're dealing with stress like this. So as an educator, we're not only educating them on end-of-life symptoms, physical symptoms, but we're also talking to them about grief and loss. We're certainly not there to tell them how to do it. They are the experts. Everyone is different. So education comes in all shapes and forms, and we're doing it on a day-to-day basis. It changes hour to hour. I'm also a companion. Yes, I provide emotional support to everybody, and that can be extended family. In San Antonio, we have a lot of that, and so it's not only the patient and the immediate family, but also extended family or their loved ones or friends that come to take care of them. It's a lot of validating and normalizing the appropriate reactions to grief. And also, I see myself as a mediator at times, trying to bring families together. So some of the emotional symptoms that we see at end of life is depression and anxiety. This is a time in their life where they're beginning to detach, that they're losing their independence and their autonomy, and that's difficult for any one of us. Anxiety about not knowing when is this going to happen, or what's it going to be like, or am I going to have pain? That's a big one. And if we can help to reassure them that we are going to address all their symptoms, pain included, and be aggressive in that, then it helps to eliminate some of that anxiety that's natural. Ineffective coping, that begins from the very beginning. When we go out for the very first visit, we're already looking to see how have you dealt with stress in your life before, and giving them the tools that they need to face these difficult days ahead. Ineffective communication. There's a lot of protecting that goes on, and it's natural. We do it as parents, we do it as children. So what we try and do is to break down those walls, those barriers of communication, and have the patients and families begin talking to one another. One of the most difficult is life role transition. We call it role reversal. You know, we're used to taking orders from our parents, and now children are being asked to make decisions on behalf of their parents, which is very hard to do. Caregiver distress and financial stress. Caregiver distress can come in many shapes and sizes. We're always looking to see, how are you coping? How are you doing? Are you getting enough rest? Are you eating? Inomi mentioned a little while ago that it's not unusual for patients at the end of life to begin to lose their appetite and may eventually stop eating altogether. That's just one thing that happens. And what we find sometimes is that caregivers sometimes feel guilty for eating when their loved one is not eating. So we're always assessing for all those dynamics, seeing what support systems are available to them, and then trying to do what we can to eliminate any financial stress that may be there. Some of the spiritual symptoms that we see are feelings of despair and hopelessness. A lot of times, patients at this time in their life, they're looking for a sense of meaning and purpose. There's a powerlessness that takes place. They don't have any control over what's going on with their body, but we try and point out what they still do have control over. There's loneliness, and the need for reconciliation is big. A lot of times, again, we're trying to bring people together if that patient wants to repair something that's there, forgiveness issues. So these are some of the things that, some of the emotional and spiritual symptoms that we see at end of life. Now I'd like to focus on what we call the 4 levels of care, and Inomi will introduce those to us.
Thank you. There are 4 levels of hospice care recognized by the Medicare hospice benefit. It's routine home care, continuous care, inpatient care, and respite care. And Lucy will discuss routine home care.
Routine home care is the most basic and frequently delivered level of care in hospice. It's provided wherever the patient resides, and that can be in the patient's own personal home, maybe a family member's home, a nursing home, an assisted living, or a boarding home. Sometimes hospices have specialized teams. The hospice that I happen to work at has several specialized teams. I am the social worker on the designated nursing home team. There's also an assisted living team. There's a cultural diversity team. In San Antonio, we have a high Hispanic population, so we have a Spanish-speaking team. There's also diagnosis specialty teams, such as ALS, otherwise known as Lou Gehrig's disease. We have that. They have special needs. And we also have a designated veterans team. These teams they receive additional training so that we can specifically address the end-of-life issues and needs of those particular patients and families.
Now let's take a look at continuous care. Continuous care is delivered in the home or wherever whatever they call that home, whether it be an assisted living or a long-term care facility. It's a short term. There's an acute symptom that's presenting in that patient. And the criteria for the continuous care is the same criteria as for the inpatient unit, and I'll tell you a little bit about the criteria. It involves intractable nausea and vomiting, uncontrolled pain, respiratory distress, changes in level of consciousness, or any other symptom that the patient or family member may find distressful. There are shifts of care. For a minimum, there's a shift of care for a minimum of 8 hours. For example, why would we have a shift just for 8 hours? Well, it could be teaching. That patient may be in the hospital, just discharged from the hospital, transferred to the home, and the caregiver doesn't know anything about bolus feeding, where they have that peg tube in their abdomen, and so they get feedings that way. Well, the caregiver is not familiar with that, so we could provide continuous care for teaching, and that would be example for minimum. It can be up to 24 hours. It depends on what's going on with the patient. Again, more than 50% of the care is provided by a licensed nurse, and then the balance of care is provided by a home health aide, can be provided by a home health aide, depending on the needs of the patient.
And I think what's important to also mention about continuous care is that it's evaluated on a daily basis.
Thank you, Lucy. For the inpatient care, there's short stays, and it's the management of symptoms that cannot be managed at home. For example, again, the criteria is the same for continuous care. But let's say a patient is on continuous care and that pain is not managed at home, then they can transition into our inpatient unit. So again, those symptoms are the same for the criteria. Shortness of breath, respiratory distress, intractable pain, again. So as we move along in the inpatient care, we have nurses that are there 24 hours. The doctor visits once a day. It's a home-like setting. There are no visiting hours. You can come and go as you please. The rooms are large and spacious. We have accommodations where the family members may stay overnight. There are chaplains and social workers available. And we have the volunteers, again, can come there. Also, with our inpatient unit, we do have, it may take place in a standalone facility or a designated hospice wing or in a long-term care facility. The hospice that I'm employed with, we have 2 units. One is freestanding and the other one is located in the long-term care facility.
The last level of care is something called respite care. And basically it's a short-term respite stay. It's usually a 5-night consecutive stay in a contracted long-term care facility or our inpatient unit based on availability, of course. It's provided on an occasional basis, and it's intended to give families a break. Sometimes they just need a well-needed rest. Other times they may have other emergencies that have come up, or sometimes they have other events in the family that they want to go to. So this is something that under your Medicare hospice benefit they can take advantage of. Coordination of care in facility settings is crucial. The hospice coordinates the patient's care with the staff in the facility settings. Like I mentioned before, the facility can be in a nursing home, an assisted living, boarding home, or a personal care home. We develop a plan of care, and of course the patient and family are at the center of that. So it's important for us to develop that plan of care and identify who it is exactly that will be delivering those interventions. The best way I can describe it is that when they're in a facility, the facility staff continues to do the day-to-day hands-on care. It doesn't change just because hospice comes on board. But what hospice provides is another set of eyes and ears and the expertise at end-of-life issues and care. So we come in and we are supplemental to all of the care that the facility is already providing.
You can ask yourself the question, when is it time? We've heard all about palliative care, we've heard about the different criteria, but when is it time for the patient to come on to hospice? When there is a life-limiting illness, when two physicians, usually the attending physician and the hospice physician, certifies that the patient has a terminal diagnosis of 6 months or less, when the patient has decided that curative treatment is no longer helpful, when the patient has says, I'm tired, like Lucy alluded to earlier, they're tired. They don't want dialysis anymore. They don't want chemotherapy anymore because they're too weak and they're too sick. It's when the burden of curative outweighs the benefits.
Now we just want to spend some time talking about what improves the quality of life for both the patients and their loved ones.
Often what we hear frequently is, I wish I had known about hospice sooner. Hospice benefits the patient early on. It improves the quality of life for both the patients and their loved ones, and it's most beneficial when it is provided for months, not weeks or days.
The Journal of Pain and Symptom Management published a research finding that indicated those Medicare beneficiaries who opted for hospice care at the end of life lived on average 29 days longer than those who did not take advantage of hospice. And BTOS Innovative Hospice Care conducted a survey that indicated that 99% of families wish they had known about hospice sooner. What we would like to do now is talk about some of the reasons that we came to hospice. People will ask us, how do you do that work? How have you done it for so long? It's sometimes very hard to put into words, but I'll let Inomi tell her story and then I'll give you a brief story of my own.
Well, I've been doing hospice for 11 years, and what brought me to hospice was I thought the hospital was a cold and sterile environment, and I wanted to assist in providing dignity to the patients. Hospice is probably one of the few areas that holistic medicine is being given. In hospice, you can do that. You have a hospice interdisciplinary team. You have the autonomy, but you still have the support that you need. Why do I keep doing what I do? It's because of the patients. Because it's the most sacred thing that I've ever done. And you can't help but grow spiritually. I'm in it because of also of my company and the kind of resources and support they provide. But I couldn't do it without the patients. Are there times that there's tears, laughter, and joy? They teach me how to live. My hospice patients teach me how to live. Lucy?
That's wonderful, Inomi, and it's so true. People will say, well, how do you do this, Lucy? Well, I've had the privilege, and it is a privilege, to walk the journey for 18 years with patients and families. And every day I learn something new. They are my teacher. And as Inomi says, they do teach us how to live. I think what I've learned most is that, first of all, there was a reason. There was a calling, I think, for me to come to hospice work. First of all, it is so satisfying and rewarding to know that you have helped somebody and helped to alleviate some of the pain and the suffering, to provide support and know that you've made a difference. All I need to do to keep going is to listen to what they say. You've been an angel on earth. You've made me feel like I wasn't going crazy. Thank you for making the time that my mom had left pain-free. All of those things that we hear on a day-to-day basis is what keeps us going. As I mentioned, they are our teacher. They've taught me to say what I need to say to my loved ones, to talk about what kind of care it is that I may want for my life. They've taught me to prioritize what's important and what's not. So you can't help but grow spiritually, and I wouldn't trade this work for anything.
Thank you, Lucy. It looks like we have a couple of questions here. Would you like the first one?
Okay.
Since it's about support groups?
Sure. This comes from Nan, and she's asking, does every hospice have a support group or bereavement program? Nan, I don't think they do. I don't know. I know that most communities do offer support groups, but even though hospice is reimbursed at the same rate, it's important for you to contact all your local hospices and see what the differences are, because there are differences in the care that they deliver as far as what they can offer to you. So I would encourage you to contact several hospices in your community and find out. There's also support groups depending on, like, Life After Loss through the Cancer Society. So I would encourage you, depending on what the disease is that you're coping with, if it's Alzheimer's, to get in touch with the Alzheimer's Association and find out what groups are available, because there are plenty of community groups. But as far as support groups available with the particular hospice, I think it's very individualized.
But our hospice does have support groups, and we meet monthly. Is that correct?
Right. We have a caregiver support group, and we also have a bereavement support group.
Thank you. Question from Toby. When should a decision about entering a hospice program be made, and who should make it? Can I just check myself in? Well, I would suggest having that discussion with your physician. He will have to make that determination if you have a terminal diagnosis. And then, of course, you have to meet the criteria, because there is certain criteria from Medicare. There are guidelines that we have to follow. You should talk it over with your family and see what suggestions they have. Lucy, do you have any other recommendations?
I would also recommend calling your local hospice, and they may be able to help you to get in touch with your doctor and see if it's something that is available to you, and if you're ready for it.
What happens is, if you're ready, then what our hospice would do is send out a nurse to evaluate you, to see if you're appropriate for hospice. You may not be appropriate for hospice, so they would send a registered nurse out or an expert to assess you to make sure that you meet the criteria, and we would go from there.
And Medicare is who sets that eligibility. It's not the actual person coming out to see you that decides yes or no. It is criteria that is set by Medicare guidelines that we're following.
We also have other insurances too that will pay for a hospice. So keep that in mind when you're considering hospice as well.
Mm-hmm. The next question is from Lily, and she asks, my father does not want a female aide or nurse. Can hospice provide male caregivers? We have individual requests frequently, and we try and accommodate the best that we can. I think, again, it's going to depend on your hospice and what's available individually with your hospice. But I think that most hospices will try to be sensitive to the needs of the patient.
The next question is from Toby. Is all hospice care the same? Let's answer that question. There's a two-part question. All hospices are reimbursed the same. However, it's the services that the hospice office offers that makes them different. For example, Lucy talked earlier about the different teams, about the veterans team, about the assisted living team, about the long-term care teams. So some hospices are not as specialized as our hospice. So all hospices are not the same.
Again, check out a variety of hospices. Sometimes you may be told by a particular facility or a particular doctor to try one hospice, but know that you have choices and that you actually can do your research. And so I would encourage you, contact several hospices and see what works best for your family and ask those specific questions. Just like Lily asked, do you have male aides that can come and bathe my dad? Those are the kinds of things that are going to differ from hospice to hospice, and so I would encourage you to call around and find out. You know what's best for you, and again, I can't stress that enough, and so go ahead and call around and see what's available.
What are the basic services that I should expect? The basic services, you should have an RN visit at least once a week, sometimes more if needed, depending on the needs of the patient. You should have a home health aide assigned to that patient. Again, how many times a week, depending on the needs of the patient. There's a chaplain and social worker. Lucy talked earlier about what services was included as far as the equipment. The hospital bed is included, the medications that are related to the terminal diagnosis, if they need oxygen, if they need nebulizers, the supplies, if they need adult briefs, if they need wound care. All those things are inclusive and covered under Medicare, hospice Medicare benefits.
Mm-hmm. Okay, let's see. The next one is written by Don, or the question comes from Don, and it's the subject of chaplains. It says, do you have all denominations represented in pastoral care? They take a non-denominational role. However, again, at our hospice we have several denominations covered, including a priest, because sacraments and rituals and things like that are often important at the end of life. So we try and accommodate. If not, we use community members that are available to us to address the specific needs of that person or that family.
And keep in mind, the hospice chaplains, they're not there to try to convert. Sometimes they just listen. Maybe their priest is not available, but they need somebody to talk to. And so maybe they're just listening, but they are there and they are available. The other thing, we have chaplains on call 24/7, not just from 8 to 5. If there are after-hours needs, we have a chaplain, social worker, and nurses on call as well. And so we're always available. We also have a triage team at our hospice. So after hours, if the patient's in crisis or the caregiver has questions, she can call that designated number, and there's an RN that answers the phone. It's not punch this number and go to this place, but you get to actually speak to a nurse, and that nurse will direct her or answer her questions, or even if necessary, send a registered nurse out to see that patient to make sure that the patient's needs are being met.
Absolutely. I'm glad you mentioned that about the on-call, because that brings such relief to families. The other thing I wanted that came to mind a few minutes ago that I wanted to mention is oftentimes people will say, you know, I don't have a caregiver. I don't have someone that can take care of me at home. At our particular hospice, it's not necessary for you. We encourage it, of course, for you to have a caregiver, but it isn't absolutely necessary. Now, what's important about that to know is that we are available 24/7, but we are not the 24-hour caregiver at the bedside 24 hours. So I think there's a distinction there, and sometimes, again, a misconception about what hospice care delivers. The next question comes from Susan, and it's in regards to HIPAA. We can't get away from HIPAA. Does the HIPAA law apply to hospice and the care that involves, and how much information is the family allowed to have? You know, this is something that comes up often, more often than you would think. But in part of the assessment process, that we have when the social worker goes out is to find out, do you have a designated medical power of attorney? We often will go straight to the medical power of attorney if the patient is not able to make their own decisions, of course. And we try and involve all of the family. So I think we start with the medical power of attorney. If the patient is able to, then we help to designate a medical power of attorney. If not, then we include as much family as the patient allows or wants, and we let the medical power of attorney be sort of the spokesperson of the family. And if they want us to talk to them, we have family meetings constantly. So it's really up to the patient and who they want the medical information to be shared with. I think our time is up with questions, but I want to thank you for allowing us to spend some time with you today.
today? Well, today